Iki aspek pasal.
Kita dari sini ya, itu enggak. Nanti belum ada sambutannya, belum ada. Dengan bajunya bersama ya, ya. Iya,
Dokter Ramelan bertempat di Jalan Gadung nomor 1 Surabaya dan berdiri di atas lahan seluas lebih dari 20 hektar. Sebagai rumah sakit tingkat 1 TNI, Rumkital Dokter Ramelan menjadi pusat rujukan bagi TNI Angkatan Darat, Laut dan Udara di wilayah timur. Dengan semangat visi Rumkital Dokter Ramelan menjadi rumah sakit terkemuka bagi TNI dan masyarakat yang mampu memberikan dukungan dan pelayanan kesehatan serta menyelenggarakan pendidikan yang bermutu. Rumkital Dokter Ramelan telah bekerja sama dengan BPJS dan menjadikan Rumkital Dokter Ramelan sebagai pusat pelayanan kesehatan PPK tingkat 3. Sehingga peran Rumkita Dokter Ramelan tidak terbatas hanya melayani anggota TNI dan keluarga, serta purnawirawan TNI saja, namun juga memberikan pelayanan kesehatan bagi masyarakat luas. Kapasitas yang dimiliki Rumkita Dokter Ramelan saat ini adalah 35 ruang rawat inap dengan 747 tempat tidur, 41 poli rawat jalan dengan layanan spesialis dan subspesialistik, serta 17 kamar operasi, didukung kekuatan personil dengan jumlah total 2.192 orang yang terdiri dari 185 tenaga medis, 847 perawat, 91 bidan dan nakes lain sejumlah 310 orang, serta 759 orang pendukung. Rumkita Dokter Ramelan mempunyai beberapa pelayanan unggulan yang mungkin tidak dimiliki oleh rumah sakit lain, yaitu unit bedah jantung terpadu, Taman Observasi Jala Puspa yang merupakan pusat gangguan pendengaran bayi dan anak, Jasmine Unit, pembuatan hand bionik, stroke unit, unit estetika, handling sitotoksit, pusat kemoterapi, pusat rehabilitasi narkotika, medical check-up dengan layanan satu atap, T-scan, MRI maupun USG Doppler 4 dimensi. Instalasi gawat darurat Rumkita Dokter Ramelan adalah sebuah gedung yang terdiri 4 lantai dengan konsep layanan terpadu 24 jam, meliputi ruang triase P1, P2, P3, P0 dan observasi, ruang VK dan tindakan obsgin sederhana dilengkapi NICU, ruang intensif care unit ICU, kamar operasi, ruang recovery, ruang intensif cardiac care unit ICCU, serta penunjang lainnya, yaitu unit radiologi, laboratorium, farmasi, ambulans, dan helipad yang siap melayani pasien evakuasi medik udara. Pelayanan penunjang merupakan unsur penting dalam mendukung terciptanya pelayanan kesehatan yang paripurna. Di antara pelayanan penunjang yang dimiliki Rumkita Dokter Ramelan yaitu laboratorium patologi klinik, laboratorium patologi anatomi, radiologi diagnostik, radioterapi, rehabilitasi medik, hemodialisa, sedangkan pelayanan penunjang klinik meliputi gizi, farmasi, sterilisasi, CSSD, dan rekam medik. Tidak kalah penting fasilitas pendukung yang dimiliki terdiri dari instalasi pengolahan air limbah IPAL dengan kapasitas 1.000 tempat tidur, insenerator, water treatment plant, laundry, pusat layanan informasi, ambulans, dan pemulasaraan jenazah. Fasilitas umum lainnya yang disediakan Rumkita Dokter Ramelan dan sangat dibutuhkan oleh pasien dan keluarganya yaitu sarana menginap guest house, masjid, musola, bank, ATM, kafetaria, minimarket, pujasera, apotek, sakit pendidikan. Rumkita Dokter Ramelan bekerjasama dengan beberapa instansi pendidikan serta aktif menyelenggarakan kegiatan dalam pengembangan pendidikan dan latihan berupa seminar, workshop, temu
sambutan saya itu nanti atas nama Pak Kasal atau atas nama saya ya? Soalnya kan orang kan Bapak itu kan jangan Pak Kasal kan ya. Jadi gimana? Oke. Nah, mari kait potong aja daripada nanti jadi masalah untuk Mas tadi ya. Kait potong lagunya kita mulai halaman ke Kritis gitu, halaman ke langsung baca. Dan kita akan bahas bagian apresiasi kita termasuk atas karena yang terkait dengan pertama saya potong aja nanti. Dan on the first day of my journal as the 26th of the semester. Oke Om G, bismillah, matur nuwun G.
Good morning, ladies and gentlemen. While we are waiting for our master of ceremonies, kindly make sure that your microphones are muted so that we will minimize any disturbances in this webinar. Thank you.
Bismillahirrahmanirrahim. Good morning. The Honorable Head of Health Agency of the Indonesian Navy, First Admiral Dr. Ahmad Samsul Hadi, Deputy Group CEO of SingHealth, Professor Fong Kok Yong, Group Director, SingHealth International Collaboration Office, Associate Professor Tan Hyang Kun, Chief Executive of Temasek Foundation International, Mr. Benedict Cheong, CEO of Dr. Ramelan Naval Hospital, First Admiral Radito Susanto, MD, Director of Health Agency, Ministry of Defense, First Admiral Dr. Ari Zakaria, Major of Surabaya, Mr. Wisnu Sakti Buana, Ketua Persi Dr. Dodo Anondo, Kadinkes Provinsi Jatim Dr. Herlin Verlina, Kadinkes Surabaya Dr. Gigi Febria Rahmanita, Ketua PPNI Profesor Dr. Nur Salam, Ketua IDI Surabaya Dr. Brahmana Askandar SPOG Konsultan. Assalamualaikum warahmatullahi wabarakatuh. Shalom, Om Swastiastu, Namo Buddhaya. My name Petty Officer First Class Rizcha and my partner Mrs. Anita. We are your MC for today. On behalf of Dr. Ramelan Naval Hospital, I'd like to welcome you to this webinar, Quality and Patient Safety in Critical Care Unit Program. Today also marks the launch of this project, Quality and Patient Safety Program in Surabaya, Indonesia. This 3-year program is a collaboration between Dr. Ramelan Naval Hospital and SingHealth with tremendous support by Temasek Foundation. Our thankful hearts to
Tak terus ya. Our thankful hearts to God Almighty, Allah Subhanahu wa Ta'ala, because His blessings and grace allow us to be here today. Our salat and salam are always given to our Prophet Muhammad Sallallahu Alaihi Wasallam. Distinguished guests, ladies and gentlemen, once again, welcome to webinar Quality and Patient Safety in Critical Care Unit Program. Due to the global pandemic, we
sorry for the technical issues. And before we proceed, we will be reciting doa by Mr. Musinin. Mr. Musinin, please.
Marilah kita berdoa kepada Tuhan Yang Maha Esa sesuai agama dan kepercayaan masing-masing. Mohon izin, doa akan saya pimpin sesuai agama Islam. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. La sayyidina Muhammadin ma'in. Allahumma ya Rahman ya Rahim. Dengan kerendahan hati kami yang paling dalam, kami panjatkan puji syukur kehadirat-Mu atas nikmat yang telah Engkau anugerahkan kepada kami, sehingga pada hari ini kami dapat berkumpul di tempat ini dalam rangka webinar Quality and Patient in Critical Unit Program dalam keadaan lancar. Ya Rob, ridhoi dan berkahi acara kami ini. Allahumma ya Jabbar, anugerahkan kepada kami yang hadir di sini dan kepada mereka yang sedang dirawat berupa kesehatan, keselamatan,
thank you, Mr. Musini. I'm sorry because of the technical. Distinguished guests, ladies and gentlemen, once again, welcome to webinar Quality and Patient Safety in Critical Care Unit Program. Due to the global pandemic, we had to put this project on hold instead of having it commence in 2020. We are happy that today we are able to launch this program, even though it has to be done virtually. On behalf of Dr. Ramelan Hospital, I would like to once again extend our gratitude to our partner, SingHealth, and to Temasek Foundation for the great support. I would like to remind everyone to mute your microphone during this webinar to avoid any disturbance. Thank you.
Distinguished guests, ladies and gentlemen, now we would like to invite the organizing committee, Captain Franz Prasetyadi, MD, to deliver the opening remarks. Captain Franz, time is yours.
Thank you. Good morning. Assalamualaikum warahmatullahi wabarakatuh. Shalom, salam sejahtera, Om Swastiastu, Namo Buddhaya. Yang terhormat Bapak Kadis Kesal, Bapak Dirkes Ditjen Kuathan, Bapak Kepala RSPAL Dr. Ramelan, Bapak Wali Kota atau yang mewakili, Ibu Kepala Dinas Kesehatan Provinsi Jawa Timur dan Kota Surabaya atau yang mewakili, Bapak Direktur Utama RSUD Dr. Sutomo, terima kasih berkenan hadir, Bapak Ketua IDI, Bapak Ketua PPNI, Ketua Persi, the Honorable Professor Fong Kok Yong, Professor Tan Hyang Kun, Mr. Benedict Cheong, all distinguished guests, ladies and gentlemen. It's a great pleasure and honor to have you all here for this important meeting. As mentioned before by the MC, this webinar marks the launch of a cooperative program between Dr. Ramelan Naval Hospital and SingHealth to hold a multi-year training for our health workers, particularly those who work at ICU and ER in the management of critically ill patients. There will be some batches, 2 to 3 per year for the whole 3-year period. And some of the training participants will be selected to join a TOT, training of trainers, that expected to be held in hospitals in Singapore. We also invite our neighboring hospitals in Surabaya, to mention some: RSUD Dr. Sutomo, Rumah Sakit Universitas Suwandi, and some other private hospitals that might interest in joining the program. Jadi kami nanti juga akan mengundang partisipasi peserta dari rumah sakit sekitar di Surabaya untuk turut berpartisipasi dalam pelatihan ini, dan yang terpilih akan mengikuti TOT di Singapura nantinya. And let me particularly mention that this whole program comes into realization as we get full support and endorsement of Temasek Foundation International. And allow me to extend our sincere gratitude to Mr. Benedict Cheong for the kind heart and spirit of collaboration. We do hope that this this webinar and the consecutive training program shall lead us to be better persons, high qualified health workers that by the end of the day will provide ultimate benefit for the sake of patient safety. Lastly, to our CEO of the hospital, First Admiral Dr. Radito Susanto, we are so thankful for his approval and support so that this webinar may take place. And also to my colleagues of the organizing committee, thank you all so much for your best efforts. And I hope you all enjoy the event, the webinar. Thank you, and wassalamualaikum warahmatullahi wabarakatuh. Shalom, salam sejahtera, Om Santi 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 Om, Namo Buddhaya. Thank you.
Thank you, Captain Franz. Next, we would like to invite
Thank you, Captain Franz, for the opening remarks. And next, we would like to invite CEO of Dr. Ramelan Naval Hospital, First Admiral Radito Susanto, MD, to deliver his speech. Time is yours, sir.
Thank you. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, good morning. Salam sejahtera untuk kita semua. Om Swastiastu. Yang saya hormati Kepala Dinas Kesehatan TNI Angkatan Laut, Dr. Ahmad Samsul Hadi, Kepala Direktur Kesehatan Kementerian Kesehatan, Dr. Ali Zakaria, CEO, Group CEO SingHealth, Profesor Fong Kok Yong, Chief Executive Temasek Foundation International, Mr. Benedict Xiong, Group Director SingHealth, Profesor Tan Hyang Kun, Mayor Surabaya, Wali Kota Surabaya yang diwakilkan oleh Kepala Dinas Kesehatan, Kepala Rumah Sakit Dr. Sutomo, selamat datang Pak, terima kasih atas kehadirannya. Kepala Persi Jawa Timur, terima kasih Pak Dodo atas kehadirannya. Para narasumber, keynote speakers of the webinar, all head of health unit facilities of the Indonesian Navy, the participants of quality and patient safety in critical care program. Ladies and gentlemen, on behalf of Dr. Ramelan Navy Hospital, I would like to say thank you for the head of health agency of the Indonesian Navy, First Admiral Dr. Ahmad Samsul Hadi, who is willing to attend as a guest of honor in this online web seminar. We also appreciated the SingHealth and Temasek Foundation for this event cooperation. Hopefully, this cooperation will provide benefits for both sides. This web seminar will hopefully provide meaningful input in giving more knowledge on critical patient handling in intensive care unit and emergency inhalation unit by the expert from SingHealth. Is attended the boost the skills and professionalism of Navy Hospital human resources in implementing critical patient handling. I, therefore, would like to urge
the participants of the web seminar to urge actively participate in this program seriously in order to earn meaningful insight and knowledge, as well as gaining the provision, the enhanced quality of service to the patients in our hospital, especially the critical patients. Therefore, I would like to express my deepest gratitude to the speakers, facilitators, for sparing your valuable time and opportunity to provide the material of online web seminar as the transfer of knowledge to the participants. Ladies and gentlemen, that is my brief address on online web seminar, the quality and patient safety in critical care program. We do hope that this program will be beneficial to us, and let us pray to God Almighty that this event will run well and can reach the desired goals. Keep on improving our dedication to Indonesian Navy Hospital, Dr. Ramelan, Indonesian Navy, and our country. Jaya Speva, Jaya Mahe. May God bless us. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, First Admiral Radito Susanto, MD, for the speech. And now we would like to invite Deputy Group CEO of SingHealth, Professor Fong Kok Yong, to deliver his speech. Professor Fong, time is yours.
Thank you very much for the introduction. Very good morning to everyone in this webinar. And I bring greetings from Singapore to all our Indonesian friends. Right? I'm sure today we will have a very good exchange of experience and sharings. Right? First Admiral Dr. Ahmad Samsuhadi, Head of Navy Health Agency. First Admiral Dr. Ari Zakaria, Director of Health Agency, Ministry of Defense. First Admiral Dr. Radito Susanto, CEO, Dr. Ramelan Naval Hospital, and Mr. Vishnu Sakti Buana, Mayor of Surabaya, Mr. Benedict Cheong, Chief Executive, Temasek Foundation International, distinguished guests, ladies and gentlemen. It is my pleasure this morning to join every one of you here at the official launch of the Temasek Foundation and SingHealth Quality and Patient Safety Program in Surabaya, Indonesia. The year 2020 was an unprecedented and very challenging year. The COVID-19 pandemic took the world by storm, affecting billions of lives, crippling economies and societies, and also impacting many healthcare systems. Now, till today, governments, frontliners, and healthcare professionals are continuing the fight against COVID-19 and are working hard to restore lives to the new normal as much as possible. Now, in the face of this pandemic, it has become evident of the critical importance of healthcare systems to be ready for all types of crises, and for healthcare professionals to be continually equipped with skills to provide the necessary care, especially in emergency situations. Temasek Foundation and SingHealth Quality and Patient Safety Program has indeed come at a very timely moment, as it facilitates the sharing of strategic skills and knowledge to upscale capabilities for improved patient care. So what is the significance of this program? I think importantly, It is the ability to respond to critical and time-sensitive emergency. And this is essential in patient care and many times make the difference between life and death. Now, SingHealth is indeed privileged to be part of this 3-year collaborative training program to strengthen advanced critical care and patient safety capabilities, to enhance quality care provided by physicians and nurses in Dr. Ramelan Naval Hospital, as well as other hospitals in the neighboring cities in Surabaya. The program is expected to train a total of 260 healthcare professionals, including 10 hospital leaders and 250 physicians and nurses. Now, of the 250 physicians and nurses who will be trained firsthand by the SingHealth team, 40 of them will be selected as master trainers. And they will in turn be able to cascade their learnings to another 150 healthcare specialists. Now, this will ensure that the learning is sustained to benefit more healthcare professionals and patients. The program will cover a comprehensive range of topics, including clinical care teams such as respiratory care, trauma care, and critical care management for the healthcare specialists, as well as healthcare leadership and clinical governance topics such as health policies and patient safety models for the leaders and master trainers. Now, these strategic and holistic topics will hopefully not only boost clinical capabilities, but also enhance the hospital's ability to respond to the challenges of the modern healthcare landscape and to ever-changing healthcare needs in both our countries. Now, in closing, and on behalf of SingHealth, I would like to express my heartfelt gratitude to the Ministry of Defense, Indonesia, for their friendship and partnership in developing this program with us. This being our first collaboration with a military hospital. I would also like to thank the Temasek Foundation for their continued support in building healthcare capabilities across borders. Now, without a doubt, this collaboration will further strengthen our friendship as we learn from one another, share best practices, and pioneer ideas to improve care in our communities. I wish everyone a very fruitful learning journey. Thank you.
Thank you, Professor Wong. Next, please welcome Associate Professor Tan Hyang Kun, Group Director of International Collaboration Office, SingHealth, to share few words. Professor Tan, time is yours.
Thank you. A very good morning to all of you, distinguished guests, colleagues from both Singapore and Indonesia. I just want to echo what Professor Fong, who has given a very good summary of the program, that we are really delighted in SingHealth to be able to partner Dr. Ramelan Navy Hospital in this 3 years capacity building program. Now, this is an impactful, sustainable program to enable the hospital to be a center of excellence for patient safety and quality in critical care. And we are confident that the structure of the program will enable sustainable impact, not just in Dr. Ramelan Navy Hospital, but also the regional hospital in Surabaya. So let me thank all the participants in advance. Over the next 3 years, I'm sure you'll be working hard towards achieving those goals. We really appreciative of the Ministry of Defense Indonesia for partnering us in this very meaningful project and walk this journey with us. And last but not least, we want to express our sincere thanks to Temasek Foundation International for its steadfast support for this capacity building program despite the ongoing pandemic. In fact, what we do learn from the pandemic is that more than ever, we are a connected world, that one part of the ecosystem affects well-being of the other ecosystem. So we are really glad of their steadfast support in these projects and have been a great partner for us in the region. So I wish everyone a very good learning and this meaningful launch for this 3-year program. I wish everyone all the very best. Thank you.
Thank you, Professor Tan. Distinguished guests, ladies and gentlemen, now please join me in welcoming Mr. Benedict Cheong, Chief Executive of Temasek Foundation International. To Mr. Cheong, time is yours.
Selamat pagi. Selamat pagi yang saya hormati Bapak Laksamana Pertama Dr. Ahmad Samsul Hadi, Head of Naval Health Agency Indonesia. Yang saya hormati Bapak Laksamana Pertama Dr. Ari Zakaria, Director of Health Agency, Ministry of Defense of Indonesia. Yang saya hormati Bapak Laksamana Pertama Dr. Radito Susanto, CEO Dr. Ramelan Naval Hospital. Yang saya hormati Bapak Wali Kota Vishnu Sakti Buwana, Mayor of Surabaya. Good morning also to my colleagues from Singapore, Professor Fong Kok Yong, Deputy Group CEO, SingHealth Services, and Associate Professor Tang Hyang Kun, Group Director, International Collaboration Office, SingHealth Services. And to all the Bapak-Bapak dan Ibu yang saya hormati, selamat pagi, good morning to everyone. Since 2007, the Temasek Foundation has supported many programs in Indonesia in healthcare, in education, in urban management. And we have around a total of 59 programs, which means every year we support around 4 programs. Our programs are meant to share experiences and build capabilities. And in healthcare, it is so important, as the professors have said, for us to share experiences with each other and learn from each other. Why is the Temasek Foundation supporting such programs? It is very simple. We believe in Temasek Foundation that if we can get our friends and neighbors in Asia, in Southeast Asia, in ASEAN together to learn, to work together, to share experiences, we will develop together. And any part of the ecosystem develops, the other part also develops and grows. So in the same way, any part of the system suffers from a crisis, the other part of the ecosystem suffers. This is the same view as we shared earlier by Associate Professor Tan. Dr. Ramelan Naval Hospital provides healthcare agencies to military personnel, but also to the general community in East Java, in Surabaya. The Temasek Foundation, we are very honored, very pleased, and very humble to partner with Dr. Ramelan Naval Hospital. This is our first collaboration, and hopefully this will not be our last. Now, I know, SingHealth know, and our leaders and partners in Dr. Ramelan Hospital and TNI know that this program will be a success because we have strong leadership from all the leaders, the doctors, the specialists, and all of you participants in this program. Your commitment, your dedication, your interest, your energy will make this program a big success. It remains for me now to thank Bapak Laksamana Pertama, Dr. Ahmad Samsul Hadi, Bapak Laksamana Pertama, Dr. Ari Zakaria, Bapak Laksamana Pertama, Dr. Radito Susanto, and Bapak Wali Kota Vishnu for your strong leadership, your strong support for this program. Without your strong leadership, without you signaling this is important, the participants will also not think so that is important. So you think that is important, they will know it is important. And we know that you have done so, and we're thankful for that. We're very, very grateful. I would also like to thank the team from SingHealth, led by Professor Fong and Professor Tan, Vijaya, my friend Grace, and all. So for all the hard work, because without you, this program, we, Temasek Foundation, we can't do much. So we need our partners like SingHealth to help us to work together with our friends in Indonesia. Now, besides thanking all of you, I want to thank the Indonesian Navy. If you look behind me, this is a model of the Indonesian ship Semarang. Now, why is this important? Because this ship, the ship that you see, Semarang, came to Singapore 3 times at least to bring back sanitizers, diagnostics kits, medical equipment, and personal protection equipment, which Temasek Foundation supported in Indonesia. Without the active support and the partnership of the Indonesian Navy, we will never be able to send all these items over to Indonesia. So I want to thank the Indonesian Navy for your strong support. This model was presented by Bapak Dubes Sutomo in Singapore, the ambassador of Indonesia in Singapore, to us as a symbol of the strong collaboration that Temasek Foundation, and indeed Singapore, the strong collaboration that we have with Indonesia. My deepest appreciation to all of you during this difficult time. So now, as I conclude, I wish you good learning. Continue to ask good questions, learn and share your learning with others, but most importantly, stay in good health. Terima kasih banyak.
Thank you, Mr. Cheong. And distinguished guests, ladies and gentlemen, let us welcome our guest of honor, the Honorable Head of Health Agency of the Indonesian Navy, First Admiral Dr. Ahmad Samsul Hadi, to deliver his speech. Kepada yang terhormat Bapak Kadis Kesal, kami persilahkan.
Assalamualaikum warahmatullahi wabarakatuh. Terima kasih PSC. Morning, selamat pagi, salam sejahtera untuk kita semua. Yang terhormat, CEO Singapore Health, Profesor Fong Kok Yong, Senior Director Temasek Foundation, Mr. Standar, Group Director Singapore Health, Profesor Tan Yang Kong, Kepala Rumah Sakit Dr. Ramelan, Dr. Adito, Kesehatan, Dr. Al-Jakaria, Direktur Rumah Sakit Dr. Sutomo, Rumah Sakit FK UNER, Pak IDI, Dr. Dodo, dan Bapak Wali Kota Surabaya yang saya hormati. Terima kasih atas undangannya. This webinar on the governance of hospital patient treatment in hospital is a great opportunity to explore and improve the knowledge of our medical personnel by learning from and discussing with medical professionals, specialists, doctors from various medical services and expertise. I would like to express our highest appreciation to all speakers, officials, and participants who have joined and supported this important event. This webinar indicates the importance of novel services to its personnel and also to the public, which is considered as one of the implementation of community services. Despite the challenge of the pandemic condition, we are still able to work and innovate in order to deliver the best quality service to our personnel and also to the public by promoting human resources development and the medical services. Peserta webinar yang saya hormati, apart from the current pandemic situation where hospitals are overhead with COVID-19 related case treatment, the nature of military duties involves high risk of personal injuries that may lead to a critical condition of the patient. Among others are those who work with explosive, which are locking and carrying mission in hazardous environment, and in harm, raise of fire, or any other damage on board warship, marine vehicles, or airplanes. In addressing this current situation, we said the COVID-19 pandemic, many people also suffer from other several critical illnesses such as typhus, ginger fever, pneumonia, and many others. These illnesses grow and live around the society. Consequently, we need a medical support which is ready and organized well, and of course supported by the best medical equipment. We have to reduce that such critical illness could endanger the life of the patient, their family, but moreover, it may impact the environment where they live. So, in this web seminar, I invite all medical personnel to find the best solution in terms of overcoming this issue. You are on the tip of the spears who fight against the illnesses. And to fight, you have to prepare all the necessary cures. Never stop your efforts to increase knowledge and skills, especially those who work in the intensive care units and emergency rooms. Ladies and gentlemen, last but not least, I encourage all medical societies to work essentially and give your best treatment for the patient. Always remember the odds of your profession and realize that even a minor and unintentional error may lead to fatality in handling a critical patient. Above all, saya percaya, I strongly believe that success comes from Almighty God. Thus, start everything with a prayer and always ask for His guidance while we are continuing our best in the form to provide and deliver the best quality medical services to our sailors, mariners, airmen, and to the greater public community around us. Untuk itu, sebelum acara kita mulai, mari sudah dilaksanakan dengan doa bersama tadi, dan izinkan pada saat ini kami membuka acara ini. By the grace of God, I here with officially launch the program Temasek Foundation Patient Safety and Quality in Surabaya, Indonesia. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera untuk kita semua.
Assalamualaikum warahmatullahi wabarakatuh. Terima kasih kami ucapkan kepada Laksamana Pertama TNI Dr. Ahmad Samsul Hadi. Dan sebagai informasi, mohon berkenan kepada Bapak Kadis Kesal dan para panelis VIP untuk tinggal sejenak. Karena setelah segmen berikut, acara akan dilanjutkan dengan sesi foto bersama. We would humbly request for you and the rest of our special guests to stay on for the photo session, which will be taken after the next segment. Moving along, Professor Ng Sin Yi, the Head Department of Surgical Intensive Care, Singapore General Hospital SingHealth, will share us overview of quality and patient safety in critical care unit program. Professor Ng, time is yours.
Thank you. I'm just going to share my slide and just do let me know whether you are able to see it. Yeah. Okay. Are you able to see my slides?
Yes, Prof.
Okay. Thanks, Dr. Franz. Okay. It is my honor to be able to be the clinical lead for this program, Temasek Foundation SingHealth Program on Quality and Patient Safety in Critical Care with the Dr. Ramelan Navy Hospital in Surabaya. At this stage, I would like to thank First Admiral Dr. Ahmad
Samsu Hadi, Head of Navy Health Agency, First Admiral Dr. Ari Zakaria, Director of Health Agency, Ministry of Defense, First Admiral Dr. Radito Susanto, CEO of Dr. Ramelan Naval Hospital, Mr. Wisnu Sakti Buana, Mayor of Surabaya, Mr. Benedict Chong, Chief Executive, Temasek Foundation International, Prof. Fong Kok Yong, Deputy Group CEO, SingHealth, Prof. Tan Hyang Kun, Group Director, International Collaboration Office, SingHealth, for your support in this program. This program started actually is the first healthcare collaboration between SingHealth and the Indonesian Navy. It started as during the Healthcare Executive in Asia Leadership Program, which was attended by senior representatives from Dr. Ramelan Hospital in 2017, and the idea was mooted. In 2019, we made a visit to a few visits to Surabaya to discuss with our friends in Dr. Ramelan Hospital to explore the possibility of a co-learning collaboration. At this stage, I would like to once again thank the Tentara Nasional Indonesia Angkatan Laut and Dr. Ramelan Navy Hospital for the great hospitality shown to us during this visit. So this went on for about 1 or 2 months of discussion between our various partners, and subsequently the quality and safety program was finalized with leaders from the Dr. Ramelan Navy Hospital, which was the host community partner, SingHealth, the content partner, as well as Temasek Foundation, which was the funding partner. The goals of this program will be to advance knowledge and skills enhancement for critical care professionals. And we aim to learn from each other and implement protocolized care and training system, which is sustainable for our healthcare systems. Through this program, we hope to develop inter-institutional exchange of ideas and experience, such that it will build upon friendship for future programs in research and education. Although it was meant to be a on-site training program in Surabaya, due to the COVID situation, we will proceed with a webinar first, series of webinars. Subsequently, as the situation improves and borders open, we hope to bring it to an on-site experience. This program will be split into multi-professionals, which will be combined learning between medical and nursing teams, as well as doctors and nursing tracks by our various leads. And through this, we hope that we can set the foundation for future co-learning collaborations between not just critical care and other specialties. And we look forward to more medical exchanges between SingHealth and healthcare institutions in Indonesia. At this stage, I would just like to thank, as well as introduce my team members who will be leading this project, in whom the participants will be seeing a lot. So the medical side, besides me, there will be Dr. Irene Wong. Nursing side will be led by Miss Lina, as well as Mr. Noel Lok. And in the International Collaboration Office, we have Miss Vijaya and Miss Irene Tan. So once again, I'd like to thank our partners in TNIAL, Dr. Ramelan Navy Hospital and Temasek Foundation for supporting this collaboration with SingHealth. We look forward to mutual learning collaboration, as well as friendship in improving systems for the care of our people. Thank you.
Thank you, Professor Ng, for the very insightful sharing. Before we move on to the next segment, we would like to invite Bapak Dr. Ahmad Samsul Hadi and all the honorable guests to join us in the web photo session. Please ensure all your camera is turned on and give your best smile alias senyum Pepsodent, ya. I hand it over to MC Ibu Rizka dan Ibu Anita, silakan. Ibu Rizka, monggo. Kak Franz, saya nggak bisa kontrol dari sini. Ya, tunggu diatur semua.
Thank you so much. A great momento, and it's certainly.
Wis foto dah.
We're very sorry for this technical issue. MC, please.
Okay, I'm sorry, and we will reply for the photo session. Please ensure your camera is turned on, and please give your best smile. Ready? One, two, three. Okay, once again. One, two, three. Thank you so much for the photo session. Distinguished guests, ladies and gentlemen, now we have arrived to the scientific session. We have moderators, Commander F. Prinsi Chandrasari, MD, from Dr. Ramelan Naval Hospital, and Ms. Grace Senke from SingHealth to lead this session. Ladies, I over to you, please.
Terima kasih, Mbak Rizka. Partner saya mana ya?
Ms. Grace, thank you. You may take over, please.
Okay, sure. Selamat pagi semuanya, para tamu yang terhormat. Good morning, distinguished guests, ladies and gentlemen. Welcome to this scientific session. My name is Grace. I am from SingHealth International Collaboration Office. While waiting for my partner, Commander F. Prinsi, to join me, let me just give you an overview of what's going on for this scientific session. So we will have 3 segments. We will start with my colleague, Professor Ng Shin Yi, the head of Department of Surgical Intensive Care, Singapore General Hospital, SingHealth, to give his overview of the critical care leadership and training in the new normal. After his session, Commander Nicholas Simamora, anesthesiologist from intensive care Dr. Ramelan Hospital, will share with us the use of high-flow nasal cannula for COVID-19 at ICU Rumah Sakit Ramelan Hospital. Last but not least, we have Miss Sifira Kristiningrum. She is the senior nurse from ICU Ramelan Navy Hospital. She will be touching on nursing care for critically ill patients at ICU Rumah Sakit Dr. Ramelan. I would like to share with all of you that after the sessions has ended, we will have a discussion where you can post your question in the Q&A button on this webinar function. Alternatively, you can post your question in our YouTube live channel. Ya, Bapak-bapak dan Ibu-ibu, saya akan memberikan ringkasan yang sangat singkat apa yang kita harapkan dari sesi saintifik ini. Sementara menunggu partner saya, Commander Efrinsi, akan saya share. Kita akan memiliki 3 sesi pada scientific session ini. Sesi pertama akan dimulai dengan pembicara Profesor Eng Shinyi. Beliau adalah kepala dari kepala dari Departemen ICU SGH Rumah Sakit Singapura General Hospital SingHealth. Beliau akan membahas mengenai critical care leadership and training in the new normal. Bagaimana kepemimpinan dan pelatihan critical care di dalam era new normal. Ya, setelah sesi beliau, kita akan melanjutkan dengan pembicara Commander Nicholas Simamora. Beliau adalah anesthesiologist, konsultan dari ICU Navy Hospital. Topik beliau adalah use of high flow nasal cannula for COVID-19 at ICU Rumah Sakit Ramelan. Dan yang terakhir, kita akan dibagikan informasi yang sangat berguna dari Miss Sifira Kristiningrum. Beliau adalah staf perawat senior dari ICU Rumah Sakit Ramelan Hospital. Dan saya ingatkan nanti sesudah sesi saintifik ini kita akan memiliki kita akan membuka forum diskusi ya, di mana jika Anda memiliki pertanyaan terhadap para panelis, Anda bisa mengetik pertanyaan Anda di question and answer button yang terdapat di webinar ini. Atau kalau enggak, Anda bisa mengetik pertanyaan Anda pada YouTube link yang sudah di-share sebelumnya. Kalau Anda lebih memilih untuk berbicara langsung, saya kira itu juga memungkinkan. Kita bisa menekan tombol record dan setelah diberikan izin dari host, Anda bisa berbicara langsung untuk menyampaikan pertanyaan Anda. So, ladies and gentlemen, if you prefer to speak directly to ask us about your questions, please feel free to raise hand. There's a raise hand button on the webinar, and we will try our best to answer your questions. So without further ado, may I invite my dear colleague, Professor Eng Shinyi, the head of Department of Surgical Intensive Care, Singapore General Hospital SingHealth, to start the session. Professor Eng, please.
Yeah, thank you, Grace. I'm
You're
just
welcome.
going to put up my screen, and do let me know if you are seeing the right screen. Yeah.
Yes, critical care leadership. Yep.
Yeah.
Good to go.
Can I just check you are seeing you're not seeing the speaker screen, right? You're seeing the actual presentation.
Yes, correct.
Okay, great. All right. Thank you, Grace. And I'd like to say a good morning to Commander Efrinsi Kandrasari, as well as my fellow speakers, Commander Nicholas Simamura, as well as Ms. Safira Christine Garom. Yeah, thank you for the opportunity to allow me to address this scientific session. So I'm very honored to be the clinical lead for this training program. And by training, I'm an anesthesiologist and intensive care physician in the Singapore General Hospital. And I look forward to working with my friends in Surabaya as we attempt to deliver this program. So I thought a lot about what to speak about when ICO asked me to give this talk. So we are going to have a lot of time together. So I thought that I'll probably not do something very academic and technical, since I think the audience for the first webinar is quite a broad group. I thought maybe I'll just share with you some thoughts I have on leadership as well as training, which I've gained over the last few years, especially last year during the pandemic. And since this session is, we are aiming to train, work with the leaders of our healthcare system. And these are some tips that we can learn from each other. And I definitely have a lot to learn from the medical and nursing leaders of Indonesia, who have been working very hard and doing a good job in combating the pandemic too. So recent development in technology, medical science, information dissemination, as well as our understanding of how people react to information and behave, has been ongoing for the last 5 to 10 years. And this has only been accelerated by the COVID-19 pandemic. In fact, most of us have known it over the last few years, and I think over exactly the 6 months or so, we have come to realize that our lives have changed, both in terms of delivery of care, managing healthcare systems, as well as training and educating our juniors, our staff. In fact, when I first started doing anesthesia and intensive care, I did it just because I just enjoyed the adrenaline. Okay, so this is Dr. Irene Wong, who is one of the leads for the program that you will be very familiar with as we deliver it. And this is Miss Lena, who is also the nursing lead for this program. You can see we are all practicing academic clinicians. And most of us started life in doing what we do because we enjoy taking care of very sick patients. And that was all why I wanted to do intensive care. So I love acute physiology, understanding why patients are sick. And I want to learn how to use drugs as well as machines, physics, to help them get better, to survive, and to get them to live a more return to quality of life. In fact, my medical school interview, the panel told me that actually they felt I was suited to be a scientist or an engineer. And they told me not to, perhaps medicine is not for me. So I thought that was the end of it. And I was quite keen to do physics or engineering. But coming from an Asian family, you know, my parents were very, very keen for me to do medicine. So I did, but I rebelled by going on to something that is very technical, as well as dealing with a lot of machines, such as intensive care. So here I am today. So over the years, I have transitioned from a practicing specialist and given the opportunity to be a clinician leader, which till today, I'm still trying to learn how to do. And I don't think I have succeeded or that well too. But let me share with you some experience with what I've learned. And I definitely do not feel that I'm ready to lead in the pandemic, and I'm still learning every day, which is why I think I have a lot to learn from my friends in Surabaya. In the clinical aspect, as a young doctor, we learn to assess, diagnose, and manage patients. However, as you become the team consultant, the leader of the ICU team, as well as the clinical head of the unit, now the job is to manage teams, prioritize resources, as well as reflect and improve on our practice, which are things our training system do not actually teach us a lot about. used to do a lot of teaching. I give bedside tutorials, teach the candidates how to set lines, give a lot of lectures, participate in workshop. But after a while, we need to transition to understanding what is it that the doctors in the future need to learn. We need to understand how they learn and how to effectively teach them. So we need to know about pedagogy, the science of learning, how to develop a syllabus within a limited time, how to teach what we think they need to know, and how to give feedback, evaluation, and assessment. In the initial stage of research, it's all about learning how to write grants, how to collect data and prepare manuscript for submission. But as we go into clinician leaders, we need to learn how to enable the future researchers to identify what are the priorities in research to move our people towards, and then develop the ecosystem and infrastructure so that they may thrive, as such that research becomes easier for the next generation. In terms of leadership in the early years, it's all about mastery and self-development. As clinicians, a lot of our identity is tied to being how good a clinician are. We all want to be the best clinician, the best doctor, the best nurse that our peers respect. However, as we move into leadership, it's all about how do we build people? How do we build a sustainable system that will outlive us? That the day we are no longer around, the system still continues to deliver good healthcare for our people. So this brings us back to this concept, which I've actually something that I've learned over the last 1 to 2 years. I read it in various books. A lot of mentors teach me about it. Is to realize that there are kind and wicked learning environment. Okay, this is started with the story that's typically quoted about this is there's a famous New York doctor that used to diagnose typhoid. He was able to diagnose typhoid by just doing a close examination of the patient's tongue. So many patients examined by him, okay, he's able to diagnose very early typhoid, and they will go on to exhibit typhoid later. So everybody thought that this was he was a master clinician, very good at examining patients. So eventually they found that the patients he examined developed typhoid because he was actually the one spreading typhoid. And hence, the lesson here is even with expertise and experience, when we try to interpret data and information, we need to know the context and environment we are practicing in. In the early training years, when life is easy, or as a young physicians, we all exist in what is known as a kind environment. Okay, so L here means learning and the learning environment, and T means the target environment. So in a kind environment, the practicing environment, which is the training environment, is exactly the same as the learning environment, or it may be fairly similar. So therefore, the rules are well defined. Mistakes can be recognized immediately, and feedback can be given, and hence the learning loop closed. There's a very close link between information, decision, action, and feedback. And therefore, many of us who are able to work hard, engage in deliberate practice, do good pattern recognition, can learn from experience and thrive. So the classic example would therefore be that of Tiger Woods learning golf. He started at 4, playing a game of chess, being a firefighter, doing individual sports, as well as practicing in classical music. In critical care, this will be the person who can read an ECG very well, who can understand hemodynamics monitoring. He's able to do procedures like lines and intubation, and he's very good at standardized exam. So this compresses of much of the critical care training as we do these days is how we train our candidates. However, as we progress, we enter this thing called the wicked environment. In the wicked environment, things are not so clear. The rules, incentives, and punishment change. Sometimes the rules of the game change without you even knowing it, and therefore the stakeholder change. There's a lot of feedback, but a lot of it is noise. And acting on feedback does not consistently lead to improvement. Sometimes you do well, sometimes you do not. It's hard to differentiate whether there is an element of luck or skill. Classic in this will be team sports. No matter how good you are, it depends. The quality of your opponents matter, and as well as your interaction with your teammates. Or improvisation music like jazz. You need to know what the crowd wants to hear, and you need to know what your groups are listening to. Okay, for those of us who like to play in the stock markets, you would have seen the classic wicked environment in the stock market situation the last few days with the GameStop shares. So in critical care, this will involve things, weekend environments are those in which you are in a triage situation where there are a lot more patients than resources available, handling end-of-life care. How do we teach trainees to think and appraise, and organizational leadership? I feel very humbled that I'm working with military leaders in Dr. Ramelan hospitals, because in the military, I think you all are well suited to manage a wicked environment in which information is coming in rapidly. You have to decide what are the information that you need to value and act upon it, and you are able to adapt to the situation rapidly. So I think these are skills which are well needed for the new environment we practice in. Let me just share with you some experience. When COVID first hit Singapore, everybody in Singapore was working with a SARS lens because we had a lot of experience managing the SARS epidemic about 20 years ago. I just came out of medical school then, and I was serving my national service in the Singapore Armed Forces. SARS was a disease that had limited spread among symptomatic patients. Many of them had high morbidity and mortality. So it was effectively controlled by early contact tracing and quarantine. We brought out our old protocols. We spoke to leaders of who managed the SARS epidemic 20 years ago. We tapped on their experience. However, while we were able to manage it well initially, because we did not realize that in actual fact, the SARS phenotype was just a small component of what the entire COVID-19 spectrum is, in which there are huge asymptomatic spreaders. There's a very wide disease phenotypes, and it was able to spread by aerosol spread under specific conditions. It was a wicked environment. We were learning, and info was coming in, and we did not realize that there was a lot more patients out there. So henceforth, while initially we had our National Center for Infectious Disease, which is a 500-bed facilities built in the lessons of SARS to cater to the epidemic. Subsequently, we realized we actually needed huge community isolation facilities, such as community isolation facilities, and this was a tasking that was led by our Deputy Group CEO, Prof. Fong Kok Yong, as well as Prof. Tan Hyang Kun, besides being Director of International Collaboration Office, was also Div Chair Surgical Care. So within 2 weeks, we were deployed out and then trained to manage these facilities and able to keep the asymptomatic or mildly symptomatic patients who was from entering the community and therefore ring-fencing it. So our leaders recognized the wicked environment and adapted to it rapidly. In the initial stage of COVID, we all were learning lessons from what our colleagues in China learned about the Wuhan intubation team. Okay, so these are the literature that came out, and we saw how well protected all their doctors were in what we call the Ebola suit, in which they were totally covered. But in Singapore, this is our level of protection. Okay, and in the initial stage, a lot of the healthcare workers felt that this was not adequate protection. The information was not clear, and everybody believed the worst. Everybody wanted to be protected like our China colleagues. And there was also, at the initial stage, the institutions were offering different standards of protection. So all of us who were on the ground were sharing what other institution was wearing. And as healthcare leaders, we needed to manage the mental stress as well as uncertainty among our staff. In fact, many of us volunteered to be front deployed with our junior doctors to show solidarity with them and to let them know that we believe our equipment is safe, this is adequate, and we engage them and make sure that their fears are well taken care of. So as a result, because we followed the science, in fact, the rate of infection among healthcare workers in Singapore, even though we are not wearing Ebola level of protection, was actually very small. And then subsequently, our doctors and nurses gained more confidence in being deployed out. In the education sector, we needed to learn how to engage with the Zoom platform almost overnight, or video platform. In a Zoom platform, we have a very huge audience. I just saw that we have 400 over people participating in this webinar, which it would be very difficult if we had done a physical webinar, I'm able to talk to you from my office in Singapore. However, are the audiences more engaged? I'm not able to see my audience physically, as well as henceforth I cannot calibrate my talk according to whether I feel the audience is interested or not. So this is one of the challenges we are learning in both undergraduate and postgraduate training, as well as professional interaction. We are still trying to learn how to do a hands-on workshop, which we have been trying to start, and we're trying to think how we can incorporate that into our sessions with Surabaya. And so therefore, a lot of times, many of us have the mindset that this is the way I was taught, and therefore I will train my trainees this way. But actually, as we move into the new future, we need to try to understand how the people learn in the new future, and therefore we should, as teachers, we should adapt the way they learn. How do we use instant polling, which is very, very popular in teaching now? And then as we do Zoom talk, there will be questions coming in on the chat box nonstop. How do we react to that? There will be instant fact check against reference. This is something I found very common in my tutorials with Duke NUS University. As soon as you say something, the students will check the internet and then send you a reference to let you know whether you are correct or wrong. And a lot of time I'm actually learning from them. So learning is on the go. This is me during a deployment to an area, to the A&E, something I've never done before. And this is the head of the Head and Neck Cancer Center. Both of us were classmates, and both of us are asked to go somewhere we have never gone before and practice in the area, so that we are not familiar with. And we have, in times of crisis, this is just something we needed to do. So our staff in the rapid period went on to think through of what are different strategies, and then we try to share our knowledge with our colleagues all over the world. Okay, so this was taught to me by a colleague from Duke University when he shared with us at one of our symposium. We need to recognize that in the future, we are working in this thing called a VUCA environment, where the situation is volatile, uncertain, complex, and there's a lot of ambiguity. What have I learned over the last few years? As we proceed to lead in leadership and education, we need to recognize the environment we are working with. We need to recognize whether it's a kind or more commonly a wicked environment. Even though we are all experienced and as well as experts in our areas, we need to be humble, okay? And I need to be aware of the limits that my experience and expertise brings, and how it may actually distort my decision making. There's too much information today, and therefore we need to differentiate between noise or data so that we can improve decision making. It's going to be an uncertain world that we negotiate in the future, and then there are frameworks for solving problems that we have not understood. We need to develop personnel who are resilient, adaptable, and having a wide domain. So together with our partners in Surabaya, Indonesia, I look forward to learning together on how to lead and educate in critical care for this new normal environment that we are going to exist in. And I look forward to the ending of the pandemic, opening of borders, such that we may continue physical exchanges and face-to-face interaction, as well as building of further friendship. Thank you once again for giving me the opportunity to talk to you, and I'll be glad to discuss this further. Thank you very much.
Thank you, Prof. Ng. I did enjoy your session, and I'm sure all of us here felt the same. Terima kasih, Profesor Ng, untuk informasi yang sangat berguna. Saya yakin teman-teman di sini bisa mengambil hikmah yang berguna, yang bisa dipraktekkan di lapangan kerja. Teman-teman, saya ingatkan lagi, jika Anda mempunyai pertanyaan buat Prof. Ng Shinye, silahkan post pertanyaan Anda di Q&A button pada webinar ini, atau kalau Anda bergabung bersama kami melewati channel YouTube, Anda bisa mengetik pertanyaan Anda di forum chat ya. Okay, ladies and gentlemen, as I mentioned before, should you have any questions for Professor Ng with regards to his presentation, please feel free to post your questions in this Q&A function in this webinar, Alternatively, if you are joining us from YouTube, please feel free to type your questions in the chat forum. Yeah. All right. We are moving to the next session. I would like to welcome my friend from Navy Hospital, Commander Nicholas Simamora. He will be touching on the topic of the use of high flow nasal cannula for COVID-19 at ICU Rumah Sakit Dr. Ramelan. Dr. Simamora, silakan Pak.
Thank you, Ms. Grace and Dr. Everything. Thank you, Professor Cindy, for sharing your experience. To all seniors and other guests, dear colleagues, good morning. Please allow me to share the slideshows. It's about the use of high flow nasal cannula for COVID-19 patient at Dr. Ramelan Hospital Intensive Care Unit. A series of acute atypical respiratory infection ravaged the Wuhan city of Hubei province of China in December 2019. The pathogen responsible for this atypical infection was soon discovered to be a novel coronavirus belonging to the family Coronaviridae and was named as the Severe Acute Respiratory Syndrome Coronavirus 2 or SARS-CoV-2. It was seen to be highly homologous to the SARS-CoV, which was responsible for the respiratory pandemic during the 2002 to 2003 period. The respiratory illness caused by this virus was termed as coronavirus disease 2019 or simply COVID-19 by the WHO. After being broadcast as a public health emergency on January 30, 2020, COVID-19 was subsequently declared a pandemic on March 11, 2020 by the WHO. The SARS-CoV-2, which initially led to a severe pneumonia outbreak in China, has now rapidly spread all throughout the globe. As of January 31, 2020, there were almost 103 million cases worldwide, with approximately 2.2 million people reported there. Although much has been discovered regarding the transmission and presentation, less is known about the pathophysiology of COVID-19. The SARS-CoV-2, which is received via respiratory droplets and aerosols, bind to the nasal epithelial cells in the upper respiratory tract. The main host receptor for viral entry into cells is the ACE2, which is seen to be highly expressed in adult nasal epithelial cells. The virus undergoes local replication and propagation, along with the infection of ciliated cells in the conducting airways. This stage lasts a couple of days, and the immune response generated during this phase is a limited one. In spite of having a low viral load at this time, the individuals are highly infectious, and the virus can be detected via nasal swab testing. The majority of patients, is about 80 to 85%, do not progress beyond this phase, as the mounted immune response is sufficient to contain the spread of infection. And then there is migration of the virus from the nasal epithelium to the upper respiratory tract via the conducting airways. Due to involvement of the upper airways, the disease manifests with symptoms of fever, malaise, and dry cough. About 1/5 or 15 to 20% of all infected patients progress to this stage of disease and develop moderate to severe symptoms. There is a greater immune response during this phase, involving the release of CXC motif chemokine ligand 10 and interferon beta and theta from the virus-infected cells. The virus invades and enters the type 2 alveolar epithelial cell via the host, receptor S2, and start to undergo replication and to produce more viral nucleocapsid. The virus-laden pneumocytes now release many different cytokines and inflammatory markers such as interleukin, tumor necrosis factor, interferon, etc. This cytokine storm acts as a chemoattractant for neutrophils, CD4 helper T cells, and CD8 cytotoxic T cells, which then begin to get sequestered in the lung tissue. These cells are responsible for fighting off the virus, but in doing so are responsible for subsequent inflammation and lung injury. The host cells undergoes apoptosis with the release of new viral particles, which then infect the adjacent type 2 alveolar epithelial cells in the same manner. Due to the persistent injury caused by the sequestered inflammatory cells and viral replication, leading to loss both type 1 and type 2 pneumocytes, there is a diffuse alveolar damage eventually culminating in an acute respiratory distress syndrome. It causing decreases in the partial pressure of oxygen in blood, such hypoxemia, and due to oxygen deficiency, cells start dying in the body. So that's how people infected with coronavirus succumb to the infection. Based on pathophysiology that we discussed previously, patients with COVID-19 infection can experience a range of clinical manifestation from no symptoms to critical illness. In general, adults with COVID-19 infection can be grouped into following severity of illness categories. However, the criteria for each category may overlap or vary across the clinical guidelines and clinical trials, and a patient's clinical status may change over time. First, asymptomatic or pre-symptomatic infection. It is individual who testing positive for COVID-19 using a virologic test such PCR or antigen test, but who have no symptoms that are consistent with COVID-19. Then the patient may develop mild illness, the one who have the various signs and symptoms of COVID-19, such as fever, cough, sore throat, malaise, headache, muscle pain, nausea, vomiting, diarrhea, loss of taste or ageusia, and loss of smell or anosmia, without evidence of viral pneumonia. So no shortness of breath, no or abnormal chest imaging or hypoxia. If it continues, the patient will have evidence of pneumonia during clinical assessment or imaging to have oxygen saturation higher than 93% on room air at sea level. Severe illness, individual who have clinical sign of pneumonia, plus one of either respiratory rate more than 30 times per minute, severe respiratory distress, or oxygen saturation less than 93% on room air at sea level. Critically ill patient may have acute respiratory distress syndrome, sepsis, septic shock that may represent virus-induced distributive shock, and or multiple organ dysfunction. So what can we do to help patients with hypoxia such as those experienced by COVID-19 patients? Referring to the oxygen delivery equation, as we can see here, is equivalent to the product of cardiac output and arterial oxygen content, where cardiac output can be likened to a transport vehicle, while oxygen content as the goods carried or cargo. Cardiac output consists of heart rate and stroke volume. We can improve stroke volume by maintaining patient hydration status, improving heart pump function, and paying attention to blood pressure. Whereas from oxygen component, we can do to maintain the hemoglobin in normal value and giving the patient oxygen to increase oxygen saturation. From the previous explanation, one of the strategies to help patients with hypoxia is by giving oxygen therapy. The following is a table of devices can be used in oxygen therapy based on the patient respiratory rate. The table tells us to provide a higher oxygen fraction to patient with an increased respiratory rate. As we can see here, the more respiratory rate increase, the more oxygen fraction we should give. This chart shows us the cascade of use of oxygen therapy devices, starting from the simplest one, nasal cannula, to the invasive one, endotracheal tube. High flow nasal cannula is recommended for patients who are still having hypoxia after using the non-reducing mask. How does that high flow nasal cannula work? There is 4 key principles that we're going to address. Number 1, flushing of anatomical dead space. 2, meeting flow demand. 3, maximizing lung mechanical like heat and humidity. And then improving metabolic expenditure. The washout of expired CO2 from anatomical dead space is reported as one of the primary mechanisms adding to the success of this device. Reducing the fraction of inspired CO2 allows more oxygen to participate in gas exchange and lower minute ventilation need. This may be result in decreased respiratory rate or tidal volume, and then that subsequently result in less work of breathing. We will see a patient kind of settle down when we do this and when we get this right. Multiple animal studies and clinical trials have reported a reduction in PaCO2, tidal volume, minute ventilation, and dead space with the use of the high flow nasal cannula. How do we know when we've met a patient flow demand? And I think we've all been there to where we put the device on. We step back out of their vision and we watch the respiratory rate on the monitor. And the patient, what we're wanting to see that respiratory rate go down, we're wanting to see work go down, and the kind of settle in as we titrate the flow to the level that is appropriate for them. Cool thing about this device is also we can ask them, how are you feeling, ma'am? Or how does that feel for you, sir? Just like that. When a device delivers high flow around 50 to 60 liters per minute or higher, the device is considered to be delivering a fixed oxygen fraction because the air entrainment is minimized and treatment will obviously be maximized when the mouth is closed. And all I got to say about that is good luck with that, keeping their mouth closed. I know how hard that is when we are really to try to do that and achieve what we want to achieve. Improved secretion clearance and patient comfort are extremely important when we give patient unconditioned medical care. It moves the isothermic saturation boundary further down the respiratory tract. This shift can damage ciliary function. It dehydrates the mucosal tissue and creates retention and secretion. Studies evaluating gas medication and human airway epithelial cells found an increase in inflammatory markers following just 8 hours of low humidity. So just 8 short hours, they saw an increase in inflammatory markers. It's really something to think about. The final mechanism of action that we're going to discuss involves metabolic expenditure. So decreasing the energy used by the respiratory muscle to breathe and the upper airway to condition the gases is our ultimate goal. When we meet the flow demands of the patient, less time is spent working and that energy is conserved. The nasal passage does a great job of heating and humidifying under normal conditions. But that system is stressed when cold medical gas is administered. This issue is resolved with the use of heated and humidified high-flow nasal cannula. And by doing that, the patient is able to conserve energy and use the energy to heal, to do what else they need to do. Here's a summary of what we've just talked about. And now, how about our experience using high-flow nasal cannula at our ICU? This is the atmosphere of the daily activities of the health workers at Dr. Ramelan ICU room. We occupied this building in early December 2020. This building is wider than the emergency ICU room, which was used from early March 2020. Luckily, we already have ventilators that have high-flow nasal cannula mode on the module. So since the beginning of the COVID-19 pandemic, we have been able to provide oxygen therapy using SFNC. However, because too many COVID-19 patients came to our hospital, the management decided to increase the number of special equipment that could only provide SFNC for patients in the emergency room who were waiting for a place in ICU. What about indication? We initiate oxygen therapy using COVID-19 management guideline issued by 5 specialist doctor association in Indonesia. That is, if oxygen saturation drops below 93% on room air at sea level. Starting with nasal cannula oxygen with flow 2 to 4 liters per minute until non-rebreathing mass with 15 liters per minute to achieve a target oxygen saturation between 92 to 96%. We use SFNC if no clinical improvement within 1 hour using 15 liters per minute non-rebreathing mass, or there is clinical deterioration. How about the procedure? First, we set oxygen flow 25 to 30 liters per minute and oxygen fraction 40%, adjusted to patient comfort in order to maintain the target oxygen saturation between 92 to 96%. And then titration up the oxygen flow gradually 5 to 10 liters per minute, followed by increasing oxygen fraction. If respiratory rate still high, more than 35 times per minute, oxygen saturation has not been reached 92 to 96%, or working of breathing still increasing, in example, dyspnea or active breathing muscle. The use of SFNC itself can be combined with the pronation position for 2 hours twice a day. This can improve oxygenation and reduce intubation demand in mild to moderate ERGS. Evaluation is carried out every 1 to 2 hours using ROX index. This prone position implemented 2 hours twice daily. If the ROX index more than 4.88 at 2, 6, and 12 hours, indicate that the patient does not need invasive ventilation. Otherwise, if the ROX index lower than 3.85, it means the patient has a high risk of needing intubation. The escalation is done gradually, starting with reducing oxygen fraction 5 to 10% every 1 to 2 hours until reach oxygen fraction 30%. and then lower oxygen flow 5 to 10 liters per minute every 1 to 2 hours until reach 25 liters per minute. Never lower oxygen flow and oxygen fraction in the same time. When 25 liters per minute and oxygen fraction 30% have been achieved, consider using conventional oxygen therapy. This table shows the number of HFNC used at Dr. Ramelan Hospital ICU in the period of September, October, and November 2020. During September, there were 89 patients using HFNC, of which 48 patients, or about 96%, had to be converted to endotracheal tube. In October, there were 56 patients using HFNC, and of which 33 patients had to be converted to endotracheal tube. In November, there were 58 patients using HFNC, and 62% of them were converted to endotracheal tube. Alexander Jimbuel et al. In Paris, France, from February to April 2020, using HFNC in COVID-19 patients with severe criteria, concluded that the number of patients who needed to be converted to endotracheal tube was 55%. This is 20% lower than patients who did not use HFNC. Jianxia et al. In Wuhan, China, also used HFNC in COVID-19 patients, concluded that the number of patients who were converted to endotracheal tube was 46%. Caligari et al. In Cape Town, South Africa, found that the use of HFNC can reduce the need for ventilation up to 47%. As conclusion, COVID-19 is a novel virus which is family coronavirus. The spread of COVID-19 can be through both droplet and aerosol transmission. 15 to 20% of COVID-19 patients can experience worsening symptoms caused by cytokine storm. HFNC can be used to increase oxygen saturation level in COVID-19 patients who remain hypoxic after wearing a non-rebreathing mask. An in-depth study is still needed to evaluate why the failure rate of using HFNC in Dr. Ramelan ICU is still slightly higher than other centers. Thank you for your attention, and I hope some of you not mind to share experience using HFNC to COVID-19 patients in your hospital at discussion session. Thank you again. Stay safe and healthy, and I offer to moderator.
Makasih Dr. Simomora untuk infonya. Saya ingatkan lagi, kalau ada teman-teman yang ingin bertanya, bisa bertanya dalam bahasa Indonesia maupun bahasa Inggris di Q&A dalam webinar ini atau di forum chat yang tersedia pada YouTube Live ya. Next session, I would like to invite my friend, Miss Sifira Christiningrum, ICU senior nurse from Ramelan Navy Hospital. She will be discussing the topic of nursing care for critically ill patients at ICU of Rumah Sakit Ramelan Navy Hospital. Miss Sifira, the time is yours. Suaranya belum keluar, Ibu. Suaranya belum keluar ya.
Okay, good morning.
Good morning.
Good morning, ladies and gentlemen. Sorry. Okay. You're healthy well today. Thanks, God. This is a great pleasure and honor for me. I will be presentation about nursing care for critically ill patients at ICU RSPAL Dr. Ramelan, Surabaya. We know COVID pandemic arrived at Indonesia in middle of February 2020. And COVID-19 arrived at our hospital, Naval Hospital Dr. Ramelan, Surabaya on March 2020. COVID-19 pandemic has suddenly challenged many healthcare systems and changed everything in lifeline. To the response, the because of COVID-19 pandemic, many systems, especially intensive care unit, with a little time to reflect on the rules to assist to our patient safety and quality improvement experts. In many cases, staff who had a background in clinical care was called to support wards and critical care. And do you know, pandemic COVID-19 make our intensive care unit many busy and make many changes with our system nursing. Quality of care is the degree to which health service for individuals and population incredible likelihood of desired health outcome. This is based of evidence-based professional knowledge and is critical for achieving universal health coverage. COVID-19 pandemic make change everything in lifeline. Okay, and then how about the hard worker, especially nurse, must be ready about the pandemic COVID-19. Quality healthcare be defined in many ways, but there is growing acknowledgement that quality health service should be effective to providing evidence-based healthcare service to those who need them and must be safe, avoid harm to people for whom the care is intended, safe for patient, safe for family, safe for health worker, nurse, physician, radiologist, physiotherapist, and etc. People center, providing care that responds to individual preference, needs, and value. To realize the benefits of quality healthcare, health service, especially intensive care unit, must be giving the service with timely to reducing waiting times and sometimes harmful delays. Please, sometimes timely, maybe a nurse very busy with a lot of patients, sometimes not care about the patient complaint. So the nurse must, health worker, the others must care about the patient complaint and awareness about the sign and symptom clinicals. And then the number 2 with equitable, providing care does not vary in quality on account of gender, ethnic, geographic location, and socio-economic status. So giving the nursing care, giving the healthcare service, it's same with the others. Integrated, providing care that makes available the full range of health service throughout the life course. And then must be efficient. Health worker, healthcare, giving the service to the patient and the family must efficient. To maximizing the benefit of available research and avoiding waste. So, nurse and ICU must have sole of caring role, coordinating role, and therapeutic role. What is caring role? Caring role is giving the caring to the patient whole, holistic, therapeutic, with biology, psychology, social, and culture. We can give the caring to patient just, no, I just care for the biologist, don't care with psychologist, no, don't do that. Must be complicated with biology, psychology, social, and culture. And then number 2, nurse and intensive care unit must become coordinating role to give in nursing care, to become caregiver and coordinate about the diagnostic to patient and giving the therapeutic to become effective and efficient. Number 3, this is the abandon rule from the nurse to giving the medicine is therapeutic role. Give medicine to the patient based off from the advice doctor. Can give become the self, not based off from advice the doctor. And 2020, the COVID-19 pandemic is very clearly referred the health challenge and risk facing health worker globally, including nurse in intensive care unit, because there's risk of healthcare associated infection, violence, stigma, psychological, emotional suffering, physical illness, and sometimes even death. That is a challenge for our nurse. Yeah. Furthermore, working in stressful environment makes her worker more prone to error, which can lead to, because stressful environment, in intensive care unit, here many alarm from ventilator, alarm from syringe pump, alarm from CRRT maybe, alarm from monitor. Sometimes make the pressure hike for our nurse. That is make risk to make harmful to patient.
So, what is patient safety? Patient safety is healthcare discipline that emerged with the evolving complexity in healthcare systems and the resulting rise of patient harm in healthcare facilities. It aims to prevent and reduce risk, error, and harm that occur to patients during provision of healthcare. A cornerstone of the discipline is continuous improvement based on learning from error and adverse event. So, nursing or health worker intensive care unit must learning day by day, never stop to learn from the errors. Don't make the sentinel event to the patient. Even the nurse is tired, even the nurse is high pressure on ICU, but please don't make sentinel error to the patient. Patient safety is fundamental to delivering quality essential health service. This is a basic, this is a fundamental. So quality health service should be effective, safe, and people-centered. And then health service must be timely, equitable, integrated, and efficient. The health worker generally, especially in intensive care unit, must have knowledge about this, must be effective, safe, and people-centered to give service to the patient, to the family, must give with timely, equitable, integrated, and efficient during nursing care, during giving treatment on the others. The burden of harm can make the nurse on ICU, intensive care unit, from the medication error, wrong to write the time to give the medication, wrong to give route to medicine to the patient. This is medication error. And then this is about the healthcare associated infection, make the burden of harm to the patient and family. Be careful with healthcare associated infection. And then unsafe surgical care procedure, unsafe injection practice. Remember, unsafe injection practice, one needle, one stick. Don't use disposable syringe with reuse again. So one syringe, one patient, one time. Diagnostic error, unsafe transfusion practice. Be careful given the blood transfusion and radiation error, sepsis, disease, venous thromboembolism, blood clots. Sometimes in intensive care unit, maybe there is so lot of the nurse have job, nurse, a lot of the patients sometimes to give the physiotherapist to the patient not full. So the careful can be venous thromboembolism to the patient. Nurse intensive care unit must be moved to the patient left or right every 2 hours. So what is patient safety strategies? The number one is must be clear policy, and then leadership capacity, data to drive safety improvement. We can learn from the data. This is maybe from the nurse sometimes not don't care about the data, but it's the data to drive safety improvement. Nurse must be care. Skilled healthcare professional and effective involvement of patients and their care are all needed. So, a nurse in intensive care unit must have skill over the others the word, I think, because that in intensive care unit need nursing care with effective, efficient. Don't to be able to give the response to the client symptom, client complaint. So 6 goal patient safety we know. 1, identify patient correctly, improve effective communication, improve the safety of high alert medication, ensure correct site, correct procedure, correct patient surgery. This is on OT. And then reduce risk of healthcare associated infection. And then the last, reduce risk of patient harm resulting from falls. Yes. How about to identify patient correctly? Patient in ICU, a lot of patients with unconscious or under the sedation. So the nurse or all health worker in intensive care unit every time will be given the medicine, given the blood product, and then makes the diagnostic, must look and check with identify patient correctly. Use 2 ways to identify a patient with name, date of birth, and number of medical record. How about if the patient unconscious of under sedation? We can use visual with the patient. We can look that patient and then cross-check with the medical record on the medical record and with electronic medical record. This is identify for patient in our hospital. Since 3 years ago, we use electronic medical record. So identification patient record on the electronic medical record. Yes, we cross-check about the name of patient, the date of birth, and then the number of medical record. When we check identification, giving the medicine, giving the nutrition, before giving the blood or product blood, and then before take the specimen, and then therapeutic and diagnostic. And then number 2, about the communication, the goals of patient safety. Improve effective communication. Must use verification, repeat of complete order or test result. The order or test result is confirmed by the individual or who gave the order or test result. Policy and procedure support consistent practice, verifying the accuracy of verbal and telephone communication. So this communication may be sometimes nurse with the physician by phone, and then right now by WhatsApp. It's like that. How about the nurse on the nurse station on the ward, intensive care unit? We are in intensive care unit, Naval Hospital, connect with HT. So must read back and must verifying the accuracy of verbal, the telephone of communication. The number 3, improve the safety of high alert medication. We know in intensive care units, so many medication high alert. Nurse must be concerned. Nurse must be awareness about the medication. Procedures are developed to address identification, location, labeling, and storage of high alert medication. Concentrate electrolytes are not present in patient care unit unless clinically necessary, and action are taken to prevent inadvertent administration. Be careful with concentrate electrolyte because become sentinel even if we not carefully to given to the patient. Concentrate electrolytes that are stored in patient care unit are clearly labeled and stored in manner that restrict access. In our intensive care unit, high alert medication, we have depot ICU. So we have pharmacies beside our intensive care unit. If needed medication, we just order by phone to request medication what I need. It's like that. Ensure correct site, correct procedure, and correct patient surgery. This is on OT. On our intensive care unit, COVID-19 lately accept the patient with sexual cassura. So, but they ensure correct site, correct procedure, and correct patient surgery. This is they implemented on OT, our hospital, with once more electronic medical record. With site marker, the body will be operate incision and then sign in, time out, and sign out.
I'm sorry, Miss Sifira. Waktu mohon dicepat.
Okay.
Kasih.
Okay. 5. The reduced risk of healthcare-associated infection. We are preventing healthcare-associated infection. This is priority area. Just not just with hand hygiene, but mass environmental cleanliness, sterilization and disinfection of equipment, device, and instrument. Medical device labeled for single use, like syringe. Yes, disposable syringe is like that. Hand hygiene with alcohol-based wrap and hand washing with 5 moments. The use of personal protective equipment, and now in our hospital, still use coverall. The safe use and disposal of self. This prevent to needle stick injury. How about the monitoring and preventing healthcare-associated infection? About because device-associated infection about prevent CAUTI, VAP, bloodstream infection, and then procedure-associated infection cause surgical site infection. All nurse and health worker must care about healthcare-associated infection, and then surveillance on our hospital in the electronic medical record. Reduce risk of patient have resulting from fall. This is must be care, must be assessment of every nurse. Health worker safety and patient safety are inseparable. The successful fight to coronavirus pandemic depends on ability to safeguard that worker. So patient safety depends on health worker safety. Yes, health workers starts, of the pandemic with many health workers pressure No, what patient safety occurs in 2020 and 2021, health worker safety is a priority for patient safety. What is goal? Prevent sub-injuries, reduce work-related stress and burnout, improve the use of personal protection equipment, promote zero tolerance of violence against health workers, report and analyze serious safety incidents. And the conclusion, patient safety is fundamental to delivering quality essential health service, especially in intensive care unit. Indeed, there is a clear consensus that quality health service across the world should be effective, safe, and people-centered, and must be timely, equitable, integrated, and efficient. Health worker safety and patient safety are inseparable. Patient safety depends on health worker safety. Okay, ladies and gentlemen, this is my conclusion, but I will show you about our activity in intensive care unit RSPAL Dr. Ramelan. This is ICU isolation before now. This is the last ICU isolation with 16 bed, 40 ventilator, and 2 hemodialysis with negative pressure. But now, with ICU isolation new, we had 23 bed, 21 ventilator, and negative pressure 2. We have 16 nurse, 15 nurse with ICU certificate, 20 nurse basic ICU not certificate, and 33 nurse from ward. So fresh graduate. Every shift, 2 nurse chief, 3 middle, and 7 nurse from ward.
Sorry, Ms. Vera.
Our
Time, please.
Yes. Okay, thank you. I hope, ladies and gentlemen, you can, this is our described intensive care unit in Naval Hospital. And now we have 23 patients with 23 ventilators. Thank you for your attention. I hope good, healthy, and God bless you all. Thank you so much.
Thank you, Ms. Sifira, for the presentation and sharing the topic and your experiences to us. Now we are going to the discussion section. We already have many questions from the participants and guests. First question, maybe to Professor Ang Shin Yi. Oh, I see you already answered the question, but maybe you could explain to us. This is the question is from Dr. Gigi Adia Ismulyanti. The question is, what is the prospect or maybe your expectation, the COVID-19 treatment in the ICU due to the COVID vaccine? As we know that it's now become trending topic and so massive and diffuse all over the world.
Thank you.
Please,
yeah, this is a common question that has been asked, and I think we're only starting to learn. Based on the data from that has been published on the Pfizer as well as Moderna vaccine. I haven't really read the Sputnik, data on Sputnik vaccine that was published in Lancet, I think just a few days ago. But the two published data are from the Pfizer and Moderna mRNA vaccine. So it seems to show that within their population, there's extremely good protection against the symptomatic and severe strain. Yes. So what is not so clear is, does it reduce asymptomatic carriers as well as the mild strain, because in these studies they only swab patients who actually presented with the symptoms. So we do know that up to 50 to 60% of COVID patients are actually asymptomatic, and they form a big reservoir of spread. But it seems to be very effective against severe disease. And if you after 2 weeks, basically 2 weeks after the second dose, nobody in the study population, which is very broad, nobody dies after that. So if this is the effect, then we can expect hospitalization as well as ICU population to drop significantly. Based on what I read in the popular press, Israel has achieved about 30 to 40% population who have received at least one dose, and their hospitalization numbers seem to be dropping steadily. And this effect has also been seen in UK. What would be more interesting is to know whether the vaccine reduces transmission. So I read a study in UK in which they swapped patients who received the AstraZeneca Oxford vaccine, and the viral carriage in the patients dropped significantly in the intervention group, which suggests that it should reduce transmission. Of course, now the change is what are the effects of the variant strains, especially the South African strain, in which the new vaccines seem to have reduced efficacy. So this is something we are still trying to find out. In general, I believe that at least on the Singapore side, we are going to maintain safe distancing measures such as wearing masks, avoiding crowds, as well as work from home strategies. And this will also be continued at the SingHealth level, even as vaccines roll out. And slowly, we will see whether we can loosen some of these measures. We believe borders will remain significantly closed. Whether vaccine will become an enabler for travel is something people are looking into, but there's no real clarity on this. But I believe patients who eventually still develop severe COVID or become critically ill, there's no evidence to say that vaccine will alter the trajectory of these patients. So if they become significantly ill, then we are back to managing them as per critical illness, in which the most established therapy currently is use of steroids. I love the talk by Dr. Nicholas on use of high flow nasal cannula, especially prone. This is something that we found to be very, very effective also. And I must say, your institution probably has managed more patients than the entire Singapore ICU population. So we look forward to learning from your experience also. But the treatment would largely be that of steroids. Whether or not who should get remdesivir and the use of immunomodulators like Tosi is something that is emerging in the trials also, and we look forward to more immunomodulation and antiviral therapy. I hope this answers your question.
Thank you, Professor Ang Sin Ye. So I think it's all our hope and expectation that with the vaccine, the population of the confirmed positive patients will decrease or drop as we should continue the research, I think, after this vaccine.
Professor Ng, we actually have one question, but the gentleman posted it in the chat.
And for the second question,
Ms. Princey, okay, I'm sharing with Professor Ng. There's one question from Mr. Muhammad Samsudin. He actually would like to ask to all our panelists, based on your experience, how do you think the stress level of the patient will impact his or her COVID treatment whilst in ICU? Prof. Ng?
Well, I think Dr. Nicholas seems to have more experience with COVID patients. So maybe, can I invite Dr. Nicholas to answer first? Then maybe I will just chip in what.
Please.
Yeah.
Yes.
Dr.
Nicholas, silakan.
Mute. Maaf, Dr. Nicholas, mute. Masih mute.
Oke. Saya mencoba menjawab. Saya rasa sama dengan pasien-pasien yang lain, faktor psikologis dari pasien sangat mempengaruhi proses kesembuhan dari pasien. Dari yang saya alami, pasien-pasien yang mengalami stressful, artinya mempunyai harapan karena berita-berita mengenai COVID ini yang seram-seram, lalu dia mengalami ketakutan yang berlebihan, pasien cenderung untuk lebih sukar untuk diobati. Jadi saya rasa, tapi ini hanya pendapat pribadi, jadi harus dilakukan penelitian yang secara ilmiah membuktikan bahwa pasien-pasien yang mengalami stres atau depresi karena penyakitnya, atau membedakan dengan pasien-pasien yang lebih berpositive thinking gitu, mereka lebih mudah atau lebih rileks dalam menghadapi penyakitnya, akan lebih cepat keluar dari rumah sakit. Saya rasa begitu, Miss Grace.
Oke, makasih Pak. Prof. Eng, do you have anything to add on? Or Nurse Sifira?
Ya, thank you so much. Terima kasih. Yang pertama saya akan menjawab yang ini, Ibu Jasmine Nadia ya. Tentang pencatatan monitoring vital sign pasien masih dilakukan secara manual dengan ditulis pada area kontaminasi. Mungkin melihatnya pas foto tadi ya, yang ada pas komunikasi pakai HT. Di ICU kami, untuk medical record-nya menggunakan electronic medical record. So, itu untuk kertas itu hanya 1 lembar setiap harinya. Kita pakai itu untuk memudahkan kita cepat-cepat nulis. Soalnya kan kalau kita pakai electronic medical record atau SIM RS, kadang itu muter, loadingnya itu lama. Kalau pas sinyalnya nggak bagus. Jadi kita itu pakai 1 kertas untuk tiap pasien di dalam ICU, area red zone. Itu pakai 1 kertas aja. Ya, setelah itu ya sudah dibuang. Tapi semuanya terekod di electronic medical record, dan itu terkonek dengan Katim atau Chief Nurse in Nursing Station. Itu yang pertama. Jadi habis dipakai, habis sudah harinya itu lewat, ya sudah kita buang ke tempat sampah untuk 1 kertas itu. Karena itu untuk memudahkan kita eret-eretan pas kita cepat-cepat keadaan emergensi. Karena kalau kita menunggu pakai SIM RS atau electronic medical record, kadang loadingnya lama. Itu yang pertama. Kemudian yang kedua, bagaimana merawat pasien dengan 21 ventilator, 23 ventilator ya, hanya dengan 2 perawat intensif terlatih, sedang yang lain masih belum bersertifikat. Laporan kejadian KNC dan KTD-nya bagaimana? Ini dari Bu Jasmine, iya. Jadi kita mempunyai 15 perawat yang sudah saya sampaikan itu bersertifikat dari Kemenkes, cuman yang lainnya ini masih belum. Hampir mungkin 80%-nya. Karena ada pandemik ini, kita planning itu kemarin kita memberangkatkan, tetapi karena ada pandemik, jadi nggak jadi kita berangkatkan. Nah, itu adalah sistem jaganya. Di setiap shift itu ada 2 katim yang di nurse station, dan 1 katim ini, kemudian yang di dalam itu ada 3 middle. Middle itu basicnya sudah lama kerja di ICU tapi belum bersertifikat. Jadi pengalamannya juga sudah banyak. Jadi itu mengcover. Dan setiap katimnya itu keliling setiap saat. 1 katim keliling. Jadi untuk memastikan tidak sampai terjadi KTD, ya sampai tidak terjadi KNC. Jadi seperti itu. Karena di nurse station juga ada dokter jaga yang selalu memonitor atau memantau melalui CCTV dan monitor sentral. Iya. Oke, kemudian.
Terima kasih, Miss Vira.
Ya. Oh, satu lagi
Pertanyaan
izin Dr.
selanjutnya.
Prinsi. Oh ya.
Maaf,
Halo?
bentar ya.
Iya.
Pertanyaan selanjutnya. Ini ada satu pertanyaan dari YouTube ditujukan kepada Dr. Niko. Ini dari Ihsan di RSPAL Dr. Ramelan. Pertanyaannya, kapan waktu terbaik untuk mulai melakukan terapi prone position untuk pasien COVID? The question is how to start the prone position with the COVID-19 patients. Dr. Niko, please.
Ya, terima kasih kepada Pak Irfan ya.
Ya, Pak Iksan.
Ya. Iksan.
Dr. Iksan
Ya.
kalau nggak salah.
Oh, Dr. Iksan. Ya. Terima kasih atas pertanyaannya. Jadi prone position ini sebaiknya dikerjakan dari mulai di setiap fase. Jadi pada waktu fase dari mulai mild symptom, jadi pada waktu masih gejala ringan, sampai pada severe. Ya, jadi kami mengerjakan pada pasien-pasien dari range yang mild symptom sampai dengan severe. Tentu saja pada pasien-pasien yang severe atau yang dalam keadaan terintubasi, hal ini membutuhkan effort yang besar karena bed yang kami miliki atau tempat tidur yang kami miliki bukan tempat tidur yang memang untuk turn pasien pada pasien yang terintubasi. Jadi itu jawaban kami bahwa sebaiknya prone position dilakukan dari mulai pasien penderita mendapati gejala sampai pasien-pasien yang mengalami severe illness. Demikian. Terima kasih. Kembali ke Dr. Prinsi.
Thank you, Dr. Nicholas. This is the same similar question to the Dr. Nicholas with the prone position, but the question is for Professor Ang Sin Ye. This is from Dul Majid, nurse at Dr. Ramelan Naval Hospital. The question is, would you explain about the prone position of COVID patients and the management spiritual needs of COVID patient on ventilator in your hospital? Maybe it means like your experience at SGH, maybe, about the prone position and spiritual needs.
At the national, prone positioning is found to be very effective in a lot of good case series, especially from Europe and China, on prone positioning, especially when combined with high flow nasal cannula. Yeah, it is thought that in some of the early phenotypes of COVID, by placing them prone, you will improve the ventilation perfusion mismatch and recruit the posterior lung of the patients. And it also helps the posterior lobes expand, and therefore a lot of this intubation may be avoided in this patient. It's very reasonable based on extrapolation from studies in ARDS when prone positioning is shown to improve survival through these mechanisms. And it seems to be if the patient is awake and fairly cooperative, it looks pretty harmless to try. So we do it, and our protocol is similar to what Dr. Nicholas have described. So patients who start on oxygen, we do put them on prone position quite regularly, and then the nurse will go in to encourage them to change positions. Yeah. And it's fairly harmless since these patients do not have a lot of things to do. So we find that we find a significant number of them improve rapidly. Yeah. However, I think in the realm of clinical trials, randomized trials, this evidence is not so robust yet. But we can't always wait for randomized control trials to guide evidence in managing a huge number of patients on pandemics. So we do like it and we do use it. And at the National ICU Committee, they do have a lot of protocols which we try to follow. Okay, so the next question is on spiritual needs. In Singapore ICUs, all our ICU patients with COVID are placed in a negative pressure room with an empty room. So isolation is a huge issue for them, whether or not in terms of communication. So if they are quite ill and they are sedated, then I mean, they may not be very aware, but there are some of them who are quite awake. So communication is a huge problem. So our social workers and nurses actually devise using video platforms to allow them to talk to their relatives on a very regular basis to communicate. However, they are not able to receive visitors at all. So one of the big issues which also reported in journals is these patients do die alone. And often at times when they die, it is only their bedside nurse that is with them in the last journey. And we have very strict protocols on how the bodies are handled also with the undertakers. So this is a huge challenge, and I think it creates a lot of mental distress among the patients. I hope that answers your question.
Thank you, Prof. Ang Sin Ye. Dan untuk Bapak Dul Majid, mungkin bisa menjawab apa yang disampaikan oleh Prof. Ang Sin Ye, dapat menjawab pertanyaannya, bahwa mungkin hampir sama di Singapore General Hospital, pasiennya juga dilakukan prone position, kemudian karena ini juga masih dalam tahap penelitian, tapi sudah ada beberapa jurnal, beberapa penelitian bahwa ini cukup efektif dan sudah dilaksanakan di banyak negara, banyak rumah sakit bahwa prone position ini. Kemudian untuk pertanyaan selanjutnya, mungkin ini dari Mayor Tri Ernawati, Diskes Lantamal. Mungkin ini kepada Dokter Nicholas. Pertanyaannya adalah, apakah perawatan pasien dengan COVID-19 juga memerlukan asesmen nyeri dan asesmen kejiwaan atau mental status? Karena mengingat sesak akan menyebabkan nyeri dan penyakit COVID-19 masih menakutkan bagi sebagian pasien COVID-19. Mungkin ini juga dokter kepada Bu Sifira. Silakan Bu Sifira.
Dr. Nico first.
Sorry, asesmen nyeri dikerjakan pada semua pasien begitu masuk rumah sakit. Jadi termasuk pada pasien-pasien COVID. Itu yang pertama. Yang kedua, apakah ada evaluasi psikologis? Tentu. Jadi pada pasien-pasien yang kami nilai memiliki permasalahan psikologis berkaitan dengan penyakit ini, maka kami libatkan juga tim psikologi dari rumah sakit kami untuk menangani pasien-pasien COVID. Mungkin Suster Vira bisa menambahkan.
Oke, thank you, Dok. Siap. Untuk pain assessment atau nyeri assessment untuk pasien dari awal datang itu sudah ada di asesmen nyeri pada pasien awal, asesmen awal pasien masuk, dan itu sudah terekod ada di sistem informasi rumah sakit kita atau electronic medical record. Jadi situ sudah ada asesmen awal tentang nyeri, ada di situ. Kemudian juga tentang psikologisnya, juga sudah ada poin-poin yang harus kita evaluasi ada di asesmen awal pertama kali pasien masuk. Lalu selama pasien dirawat di rumah sakit, itu pasien-pasien dengan COVID-19 pasti ini beda. Pengalaman kami di di ICU selama Maret sampai sekarang itu hampir 1 tahun, pasien-pasien dengan psikologisnya yang mungkin kurang bagus, maaf, untuk angka kematiannya lebih tinggi daripada pasien-pasien dengan yang psikologisnya bagus, dalam arti dia semangat, dia positive thinking. Nah, semangat dari harian klinis pasien itu bisa kelihatan, dan itu angkanya biasanya untuk angka harapan hidupnya lebih tinggi. Dan juga dari tim kita, dari tim DPJP, dari tim perawatan ini, untuk psikologisnya kita konsulkan ke dokter jiwa. Kadang kan mungkin pertama kali datang atau selama dirawat dengar alarm tang ting dong tang ting siring, pam ventilator, mungkin CRR dimonitor dan lain sebagainya. Kemudian hiruk pikuknya perawat yang tidak pernah never stop to jalan-jalan. Jadi senantiasa sibuk, kemudian ya tetangga kanan kirinya kok meninggal semua. Itu seringkali membuat psikologinya pasien dengan COVID-19 ini akhirnya menjadi down. Dan dari physician kami atau dokter DPJP kami biasanya dikonsulkan ke dokter jiwa. So, ini adalah peran perawat kita, karena perawat kita di sini yang sudah saya sebutkan tadi, every shift, tiap shift itu satu perawat bertanggung jawab responsibility terhadap kurang lebih 2 pasien. Jadi mereka merawat 2 pasien itu sudah nggak kemana-mana selama dia jaga. Ya, jadi ternyata memang supportnya ini lebih bagus daripada yang dulu kita masih di ICU lama itu, yang karena memang kurang personil, kemudian lingkungannya juga tidak mendukung. Tapi ternyata sekarang lebih baik lagi karena satu perawat merawat 2 pasien. Jadi seperti itu. Jadi supportnya dari tim perawat kami harapkan lebih bagus lagi, dan itu benar-benar kita rasakan pada 1 bulan terakhir Januari ini. Jadi seperti itu, Mayor. Terima kasih.
Terima kasih Bu Sifira. Terima kasih sudah berbagi pengalamannya juga dalam menangani pasien COVID-19 ini di ICU. Next question is from Dr. Retno Wisanti. She is a pediatrician at Dr. Ramelan Naval Hospital. The question is for Professor Ang Sin Ye. The question is, what efforts are being made at SGH, Singapore General Hospital, to protect health workers from the transmission? Maybe yes. What could we do here to from we learn from the SGH?
Yeah. Yes. So for there's a lot of efforts which starts in we have at our hospital group level, we have a disease outbreak task force, which is actually headed by our Deputy Group CEO, Prof. Fong, previously, that spoke previously. So this group sets the direction and standards for healthcare protection for each hospital. And each hospital has an expert committee of infectious disease as well as epidemiology physicians that guides us on the requirement. So in terms of PPE, I think I mentioned it on my talk. In fact, I'm very impressed that you have the PPE that we actually want, that all of us wanted, but based on the reading of the evidence, it suggests that it's not necessary. The one that you cover the entire patient like a spacesuit. So in the early pandemic, all of us wanted to use that, but we do have it in Singapore, but it's reserved for cases like Ebola. So we are using the yellow thing that we are not very happy with. So far, it seems like we are quite protected. Okay, so we work with national procurement agencies to make sure there's adequate personal protection equipment available. Based on our understanding of the disease, it is a droplet disease with potential for aerosolization during certain procedures in poorly enclosed space. So our group actually identified what are the procedures for which N95 mask is necessary with eye protection, and we also have powered air purifying respirators available. So the supply chain is actually very important, and I must thank our COO to make sure that for making sure that we did not run short of our personal protective equipment. So that was great. So in terms of patient management, we have an internal hospital system that defines the risk of the patient. So patients in whom we know that they are COVID positive are easy to handle because straight away they will be isolated in the isolation wards, which have negative pressure rooms. The challenge is to figure out which of the patients from the community are infected and with risk of infection, in which is not known, because this group will lead to infection of healthcare workers, fellow patients, as well as loss of capacity of the system. So SingHealth have quite a clear definition. We identify patients from epidemiological risk as well as clinical presentation. So this epidemiological risk changes regularly. Initially, the patients that were high risk are those from the dormitories, our migrant workers. And currently, it's patients who are imported, who have just traveled overseas because community transmission is low. So in terms of presentation, we have the very high risk presentation, such as pneumonias, then followed by the lower risk presentation, such as loss of smell, acute symptoms for acute respiratory infection. So once every patient that passes through us get risk stratified, and then they will go to the appropriate care areas. Yeah, and then the PPE for the different areas are specified. In terms of the way we work, we are not allowed to gather in crowds. We are supposed to use video conferencing as much as possible. Our administrators are on a work from home basis, so they only come to work 1 to 2 days a week. The rest of the time, they try to do their things at home. Then there's a very strict audits in which we check to make sure our doctors are not crowding. In terms of dining, which we love to eat together, there are rules. In fact, we are not allowed to eat together. So all of us, every day, we just get our food and we're very sad. We just eat by ourselves. And then any doctors presenting with illness can only, healthcare workers can only report sick in the hospital, either at our staff clinic or at our A&E. We cannot go to outside doctors. And if you present with any symptoms, they will just give you a medical leave and then you get swabbed. Yeah, so some of my friends have been swabbed 4 or 5 times during this pandemic already. Fortunately, I have not been swabbed yet. Yeah. And recently we started vaccination for healthcare workers. So in terms of SingHealth, all the healthcare workers and our even our administrators are getting the vaccine. So that will give us a lot of protection. So for me, I got my second vaccine on Monday. So in 2 weeks' time, I should be well protected, hopefully. There's some degree of only when we first asked our population, only about 60% of our workers are willing to get vaccinated. So there's a lot of engagement with our staff to convince them that it is safe and is in their interest to do it. So a lot of times the healthcare leaders needed to be the first one to get vaccinated. Yeah, and currently the vaccination program is coming along in SingHealth and is being rolled out to the general population. This is a topic we can talk about extensively. So perhaps if people are interested, we can incorporate it into the subsequent webinars.
Thank you, Professor Ng. Yes, we could looking forward for the next events or next webinar. I think the topic is still become favorite topics for the whole year 2020 and now 2021. And maybe it's the same as here in Indonesia. How to stop the transmission between health workers is the same. We still need the epidemiologic research and maybe to improve the system in the hospital, internal hospital. So, and the same like at your hospital, we divide the workers to work from home. We call it work from home here, but maybe it's mostly for the administration, but it's due to the lack of the, not like the what the nurse and doctors is minimal, but maybe it's not all division with have the work from home. And maybe it's the last question. We have many questions at Q&A. Banyak pertanyaan dan mungkin ini pertanyaan terakhir. Question is for Prof. Eng Sinye and Dr. Nicholas from Dr. Fanny at Mediato Suratani Naval Hospital. Jadi pertanyaan dari Dr. Fanny di Rumah Sakit RSPAL Mediato, Tanjung Pinang. Question is, I read about negative pressure ventilators shows promise for COVID-19 patients. In your experience,
I am not familiar.
Your experience.
Yeah, I saw the, but I must say I'm not familiar.
Would possibly
with,
bring better outcome.
Yeah. Yeah, I'm sorry, I'm not familiar with negative pressure ventilators. Is that, does the person who asked the question meant the iron lung ventilator, or because most ventilators are positive pressure? Yeah, yeah. So I'm not too familiar with that. Yeah, maybe Dr. Nicholas have some
maybe
input.
it means ventilator in negative pressure room, or but still positive pressure. The ventilator always positive pressure. Mungkin Dr. Nicholas bisa menjawab.
Saya tidak terlalu jelas juga dengan pertanyaannya. Apakah yang dimaksud ini adalah negative pressure ventilation yang seperti Prof. Cindy tadi bilang bahwa itu adalah bentuk iron ventilator waktu zaman dahulu kala, atau pasien yang diberi ventilator pada ruang tekanan negatif. Kalau statement yang pertama yang ditanyakan, jawabannya saya tidak punya jawaban karena saya tidak punya pengalaman menggunakan negative pressure ventilation. Begitu. Kalau untuk pertanyaan kedua, apakah pasien dengan tekanan negatif dan tekanan positif itu hasilnya berbeda? Saya jawab, tidak ada perbedaan bermakna pada pasien yang dirawat di ruang tekanan negatif atau di ruang tekanan positif. Karena tekanan negatif itu ditujukan untuk melindungi environment, jadi bukan untuk si pasien, tapi untuk lingkungannya lebih diutamakan. Terima kasih.
Ya, makasih Dr. Niko. Jadi mungkin kepada Dr. Fanny, jadi kalau ventilator mungkin semuanya positif pressure, tapi ruangannya diharapkan ruangan yang negatif pressure. Dan kalau ruangan negatif pressure sebenarnya itu bila dibandingkan dengan ventilator dan penggunaan HFNC, high flow nasal cannula, bukan untuk melindungi pasiennya. Kalau outcome ke pasien mungkin hampir sama, tapi kalau negatif pressure-nya fungsinya untuk lingkungan dan untuk nakesnya, tenaga kesehatannya. Mungkin begitu Dr. Niko?
Iya.
Yeah. For Professor Eng Sinye, I think Dr. Niko means that the outcome between the patient, COVID-19 patient with the ventilator comparison to the use of high flow nasal cannula, there's no different outcome. I think according to Dr. Nicholas, it is the same, but the negative pressure is to reduce the risk for the health workers or the environment of the patients. I think that's the last question. Dan masih banyak pertanyaan di Q&A di Zoom maupun di YouTube. Mungkin pada untuk beberapa pertanyaan yang belum terjawab, nanti akan tidak terjawab secara langsung, mungkin akan dijawab melalui kolom chat atau kolom Q&A dan juga di chat di YouTube. Rupanya waktu sudah berjalan begitu cepat, sekarang sudah melebihi batas dari waktu yang ditetapkan. So, it's time to close the scientific and discussion section. Thank you to Professor Eng Sin Ye, Dr. Nicholas Simamora, Miss Sifira Christiningrum for the presentation, and Miss Grace, all participants and honorable guests. Thank you. We look forward to seeing you all at next events or webinar. Back to you, Miss Rizka.
Okay, thank you so much for our moderators and all keynote speakers. Such a inspiring and useful discussion for today. And we would like to invite all VIP panelists to join us in a web photo session once again. And so please ensure your camera is turned on. Okay, ready? On the count of 3. 1, 2, 3. Okay, thank you so much for the photo session. On behalf of the organizing committee, thank you everyone for attending the official launch of this program and the symposium. Special gratitude to Mr. Benedict Cheung, the Chief Executive of Temasek Foundation International, for the great support and kind friendship. And thank you to the Honorable Head of Health Agency of the Indonesian Navy, First Admiral Dr. Ahmad Samsul Hadi. Thank you, our friends from SingHealth, Professor Fong, Professor Tan, Professor Ng, for spending your precious time with us here. And thank you for CEO of Dr. Ramelan Naval Hospital, First Admiral Radito Susanto, MD. We trust the knowledge shared in this webinar will bring inspiration and positive impact for all of us. If there's any inconvenience caused by technical glitch, misspelled of name, or other things, please accept our sincere apologies. We look forward seeing you again in the next event. We wish everyone a good health and stay safe always. Thank you, good afternoon, and wassalamualaikum warahmatullahi wabarakatuh. Shalom, Om, Santi, Santi, Om.
Thank you for all of you.
Thank you.
Thank you, Prof.
Thank you, everyone. It was a great start.
Thank you.
Yeah.
Thank you. Well done. Yeah. Thank you.
Forward to seeing you all. Thank you.
Thanks. It was
Thank you,
very,
Dr.
very
Frank.
well done. Thank you so much. Dr. Frank, did I hear you just now? I must really, really thank you and your team.
Yeah, we also thank you for your cooperation and big support from your part. And to especially to our CEO, Admiral
Yes.
Dr. Radito. Yeah, we are very grateful and for your approval and your support. Thank you so much.
I also liked the speech. It was very good. Yeah.
Yeah.
Thank you so much. Yeah.
Okay. Yeah.
Thank
Bye-bye,
you.
everyone.
Bye-bye. See you. Thank
Bye-bye.
you.
Stay safe.
Thank you, Irene.
Thank you.
Thank you, Grace.
Bye-bye.
Bye.
Bye.
Doctor. Yeah, bye.
Duh, Chris ini juga cantik.